My name is Tyler Nelson. I am going to be moderating today's session. It is my pleasure to welcome Dan Arendt. Dan's an associate professor at the University of Cincinnati in the James L. Winkle College of Pharmacy. He is a chair of the Pain Stewardship Program at UC Health, and he practices as a pain and palliative care pharmacist at the University of Cincinnati's Medical Center. In addition to his work in pain management, he's a really strong advocate for harm reduction, and he was instrumental in the development of harm reduction vending machines in the Cincinnati area. And his research into this impact has contributed to the development of a national practice brief from the CDC regarding their utility in advancing public health. Professionally, he serves as the Director of Legislative Affairs for the Ohio Society for Health System Pharmacy and as the US-based representative for the International Association for the Study of Pain's Guideline Development Task Force, related specifically to the use of controlled release opioids in the postoperative period. With that, I'm going to turn it over to you to tell us about buprenorphine versus full agonist opioids for acute postoperative pain management. Thank you again for volunteering to do this.
Absolutely. Thank you for having me, and welcome everybody. I intend to, yes, I have slides and this is a presentation and whatnot, but at the same time, the whole purpose of this is for everyone to feel like you get something out of it, like you feel more comfortable with what the study is or where buprenorphine might fall into therapy. So please feel free to let me know, ask questions, interrupt me, raise your hand, whatever needs to happen, just to make sure that you all feel comfortable with it. But we're going to be talking about buprenorphine and how it compares to full agonist opioids in the management of acute postoperative pain. We're going to be looking specifically at a systematic review and a meta-analysis today. I do have a link here or QR code for free article access. So if someone has not looked at this study before, or they want to pull that up so they can read alongside or ask further questions, or if I don't go into enough detail or anything like that, feel free to scan that link here. I'll also put the PubMed ID in case that's helpful. But it's just a little bit of a background. So why are we doing an assessment of buprenorphine for acute postoperative pain? Why does that matter? I know this is international, but I'm going to kind of focus a little bit more specifically on the US in terms of the opioid and overdose epidemic, in part because it is one of the countries significantly impacted by the opioid epidemic, and we use more opioids than pretty much anybody else, and also because that's where I'm located and what I'm able to speak towards the best. But a lot of these trends are also things that we see happening elsewhere as well, and so they're still quite relevant. But when we look at the opioid epidemic, the major turning point in really recognition of the opioid epidemic started in the mid-2000s, where we started realizing, hey, we're prescribing a lot of these opioids, and there's a lot of addiction and overdose death, and there's a lot of consequences here, and maybe there's a connection to how we're using opioids in healthcare. So in that kind of mid-2000s, you start recognizing that, and then by about 2012 is when opioid prescribing really peaked in the United States, about 255 million prescriptions a year. Now, part of that is, Tyler mentioned, I work in pain stewardship, and part of the response to this there's been a lot of creation of opioid stewardship programs and pain stewardship programs and whatnot, seeing as how can we address this issue? How can we try to solve this problem? And with that increased recognition, we saw a drastic reduction in opioid prescribing. From 2012, where there was about 255 million prescriptions for opioids, down to 2023, where we see 125 million. So in just over 10 years, the US actually cut our opioid prescribing in half. So consequentially, you would think, oh, well, that sounds great. We probably solved the opioid epidemic. But unfortunately, that's not the case. And there's actually a fair argument that in some respects, we might have made things worse. Back in 2012, if we look over here on the left-hand side to overdose deaths, we see between prescription opioids, a little bit under 20,000 overdose deaths a year. That number has steadily risen What's interesting is that prescription opioid deaths have stayed similarly level, but there's been a massive spike here in synthetic opioid deaths other than methadone. And really what this is driven by, the vast majority of this is illicitly manufactured fentanyl in the drug supply. So in the same decade that we have cut opioid prescribing in half, we've gone from around under 20,000 opioid deaths per year to around 100,000. So we've multiplied the overdose deaths by about 5 times while cutting the opioid prescribing in half. So where that kind of puts us currently. So we've seen that paradoxical effect. So overdose deaths right now are kind of the major priority or biggest consequence of the opioid epidemic, but these are primarily driven by illicitly manufactured fentanyl, not necessarily prescription opioids anymore. That being said, we still have a large focus on opioid prescribing in the United States, but there are continued reports, especially in our chronic pain patients, where we're seeing patients have their opioids abruptly discontinued or being forced to taper off of them, and patients who have been on long-term opioid therapy, just having providers essentially say, hey, this is not the treatment approach I would use. I know you've been on it, but this is not what we would recommend anymore, so we're going to stop it, or at least you need to get off of it. There's been an increased number of reports of those abrupt discontinuations also impacting the risk of, one, obviously inadequate pain control, but there's actually been a lot of reports of suicide related to withdrawal and inadequate pain control after these abrupt discontinuations. One of the most famous cases was actually in Louisville, Kentucky, which is just about an hour south here of Cincinnati. And in Cincinnati, Lower Ohio, Kentucky, West Virginia are some of the areas hardest hit by the opioid epidemic. So we're seeing inadequate pain control and inadequate consequences to patients with long-term opioid therapy, but we're also seeing an increase in overdose deaths overall. So there's a paradoxical effect there that clearly just targeting opioid therapy, and specifically targeting opioid therapy in patients who've been on it for long term, may not be the best way to respond to the opioid epidemic. So really there's an increased focus now on how do patients get their start with non-medical opioid use and what can we do to target that. Back in the 1960s, about 80% of those who were seeking treatment for opioid use disorder reported that their first opioid that they used was heroin. In the 2000s, though, this has changed to where about 75% of those seeking OUD treatment said that their first opioid use was with a prescription opioid. So there's still a big connection between prescription opioids and when people start opioid use, but it may not necessarily be related to those who are on chronic long-term therapy. With that in mind, there's been an increased focus on postoperative prescribing. Because the more that we look into postoperative prescribing in the United States, we tend to see that it is a bit excessive. So on average, surgeons prescribe about 2 to 5 times more opioids than patients actually consume. Only about 25% of patients actually store their opioids in a locked container. Most simply just keep it in their pill vial in a bathroom or a cabinet or something that's fairly easily accessible. There's been increased attentiveness to proper opioid disposal methods, disposal bags, drug take-back days, etc. But less than 9% of patients actually use those recommended disposal options. So we're seeing excess postoperative opioids prescribed. We're seeing their questionable storage methods and then also questionable disposal methods. So while we want to increase proper storage and disposal, we also need to work on adequate prescribing and not excess prescribing, but also, is there a way to prescribe something that is slightly less concerning than some of our full agonist opioids, especially if there's going to be continual challenges with storage and disposal? So that really brings us to this study today talking about buprenorphine. The other kind of consequence here is that you can't just say, oh, well, opioid use is a concern. In post-op, we tend to use too many opioids, so maybe we should just not use opioids. Because then you're typically going to run into really inadequately controlled pain, and that has consequences too. Poorly controlled post-op pain can frequently progress to persistent post-operative pain, and some studies looking at thoracic surgeries found that up to about a third of patients actually can develop persistent pain post-operatively, and many of those patients then actually require long-term opioids to manage that pain, which we know carries risks like dependence, opioid use disorder, and potential overdose. So where things come to buprenorphine. So buprenorphine is a partial mu receptor agonist comparatively to oxycodone, morphine, Dilaudid, etc., which are full mu opioid agonists. Now, it is a mainstay of opioid use disorder treatment, but it actually was originally created as an option for analgesia. It was then found to be helpful and useful for opioid use disorder. But just because it's used in OUD does not mean we should discount its potential benefits as an analgesic. Another really important thing about buprenorphine is it has a low risk of diversion. About less than 1% of patients who report using opioids recreationally report using buprenorphine. And of patients with opioid use disorder who have used diverted buprenorphine, about 80% of the time they're actually using it non-medically, but therapeutically to reduce withdrawal symptoms and cravings. So it's not commonly diverted, and when it is diverted, it's typically used for with management of withdrawal. And I think that's important context because we also see a really inadequate accessibility of buprenorphine treatment in the United States. It was still typically ignored in the postoperative period for a long time because it could potentially impact the efficacy of other analgesics. But what they found is actually stopping buprenorphine in patients with OUD in the perioperative period was actually found to worsen pain outcomes and also makes it difficult because then you have to get your patient back onto buprenorphine afterwards. So that kind of recognition of for OUD patients, we shouldn't stop their buprenorphine. We should be continuing it in the perioperative period, one, for the OUD perspective, but two, just for good pain control, really led us to this study of saying, how does buprenorphine work for patients who don't have OUD? What if we just used buprenorphine as an option for postoperative pain control? It still has a fairly quick, effective peak onset, both with IV and sublingual formulations. And it's been studied in the past, but the other systematic reviews have been a little bit more limited in scope. So they've only looked at comparisons to morphine, or they've looked at just certain formulations, or they've just looked at pediatric patients. So this study really tried to broaden that and say, how does buprenorphine compare in terms of its efficacy to opioids as a broad class, specifically the management of postoperative pain, and does its unique pharmacologic profile reduce the side effects or risks of opioid use? So this is a systematic review and meta-analysis. They specifically included randomized control trials only. For those randomized control trials, they included studies whose patient populations were adults with perioperative pain, so they did not include pediatric patients. The intervention that they looked at was buprenorphine. It was just buprenorphine as a whole. There wasn't a limitation on the form. It could be IV, IM, sublingual, transdermal, etc., a PCA. They just looked at, are you looking at buprenorphine as a drug for postoperative pain? For comparators, they included any other opioid. So if you're comparing buprenorphine to another opioid in a randomized control trial for perioperative pain, you're likely going to be included in this analysis. They wanted to look at studies that had an outcome specifically of quantitative pain scores. So some quantitative or objective marker of the patient's pain, whether it was a visual analog score, the numeric rating scale of just rating it from 1 to 10, or categorical scales. To try to make things simple from a conversion standpoint, for categorical scales, if there was multiple categories, they tried to convert that to a numerical scale. So for example, if there was 4 categories, you could be rated as 0, 1, 2, or 3. They would then classify that as no pain, mild pain, moderate, severe pain, and assign a representative number on it. Really importantly, they excluded patients with chronic pain and then excluded any studies that were not in English or didn't have a translation available. And specifically, that chronic pain component is really important for context here because for patients who are on opioids, how you initiate or use buprenorphine is critical because if you use too high of a dose to someone who is dependent on other opioids, you're likely going to precipitate withdrawal. And not only will you not see effective pain control, you're probably just going to make them very sick in the meantime. So that's an important thing to consider here. For the studies, they looked at any studies basically since inception until February 2024. They looked at Medline, Embase, Cochrane Review, and Web of Science. And the nice thing that they did is they had 2 reviewers independently screen all of the abstracts to figure out which ones they wanted to review. If there were any discrepancies there where one reviewer said one thing and the other said a different thing, they had a 3rd independent reviewer arbitrate those disagreements. After they went through the abstract process, then they did the exact same thing with the full evaluation of the studies. And again, any disagreements about inclusion or exclusion was arbitrated by a 3rd reviewer. Ultimately, that left them with 58 studies from 1977 to 2023. There are a ton of studies here. Again, 58 studies, so hard to adequately describe all of them. But in general, they use a variety of different buprenorphine formulations. So IV, IM, sublingual, PCAs, transdermal buprenorphine. But I tried to bold what was really most common here. The vast majority of these studies use IV or IM buprenorphine. Again, they compared it to any other opioid. So that includes morphine. Morphine was the most common. More than 30 of the 58 studies compared buprenorphine to morphine. So that really is driving a lot of this response. But any other studies or any other opioids were included. Fentanyl, oxycodone, tramadol, and also some kind of weirder, out-of-date opioids that we don't typically use that much, like pethidine, meperidine, and nalbuphine and whatnot. Nalbuphine, interestingly, is a partial agonist as well, but we'll talk a little bit about that later and how that is impacted in the results. Wide variety of procedures. Again, they just looked at postoperative pain. They didn't specifically look at certain surgical types. So they included literally whatever types of surgery. That being said, the vast majority were abdominal surgeries or cholecystectomies. You can actually see just from the small snippet of studies here, these are all either abdominals or cesarean sections, or in this one, it's just surgeries expected to result in moderate to severe pain. So it didn't even put really a classification there. Other themes here, most of the studies were about 20 to 50 people in each group. So looking overall between the 58 studies and the different groups of comparison opioids and buprenorphine, that gives us about 1,303 patients on buprenorphine perioperatively and 1,284 patients that got other opioids perioperatively. Again, the majority of the studies were abdominal and cholecystectomy studies. Most commonly, they used parenteral buprenorphine and parenteral morphine, but again, they also use different forms. What they took a look at is what actual dosing ratios were used in the studies. So you can actually see here when they're actually comparing them, they looked at what was the equivalent amount of sublingual buprenorphine or IV buprenorphine, what was the amount of opioid that they or morphine that they used or other full agonists to see how potent were they considering buprenorphine comparatively as an opioid. In general, what they found is that the IV bup to IV morphine comparisons found that they typically used a comparison of 1 milligram of IV buprenorphine to 48 milligrams of IV morphine. For sublingual bup, they compared that to PO morphine. So they found about 0.76 milligrams was considered equivalent to 29 MMEs in the study. Looking at BUP's just overall bioavailability, 100% obviously with IV administration, but sublingually is much less at about 30%. So for buprenorphine, sublingual BUP is 1 milligram is about 0.3 milligrams IV, and morphine 30 milligrams orally is about 10 milligrams of IV. So if you look at that, based on bioavailability, the ratio that would show us would be about 1 milligram of IV buprenorphine being equivalent to 33 milligrams of IV morphine. And for sublingual, to keep it consistent, they'd had their ratio of 0.76. So if we were to use 0.76 milligrams of sublingual buprenorphine based upon bioavailability, that would estimate about 23 MMEs. So what that actually shows us is the studies that were included here used actually more potent estimates for how effective buprenorphine would be. likely more aggressive estimates of how effective buprenorphine is going to be than what we would typically use in practice. And that actually favors the morphine group. You're expecting buprenorphine to do more despite using lower doses. So you're actually going to give yourself a better opportunity to show a benefit of morphine compared to buprenorphine, which is important context for considering how to interpret our results. For abstracting of data, again, two independent reviewers. They took a look at adverse drug events, so nausea, vomiting, dizziness, sedation, drowsiness, respiratory depression, pruritus, hypotension. Those are really the most common adverse drug effects. They looked at study quality and bias, so what was their randomization process? Did they deviate from the protocol? Are they missing outcome data? How did they measure the outcome data? When they had multi-arm protocols, this was quite interesting. They evenly split them. So say they had a study that had 3 arms. So they had 30 patients on bup, 30 patients on drug A, maybe that's morphine, 30 patients on drug B, maybe that's oxycodone. They would actually split this buprenorphine group. So then they would do 15 bup patients versus drug A and 15 bup patients versus drug B. Their rationale for doing that is that would prevent them from, if there was really positive results in this group of 30, not double counting that and getting extra benefit from the buprenorphine. For the long duration of action, because bup has a longer duration of action compared to other short-acting opioids, if they were studying pain scores based on a duration or based on an expected time period that exceeded what they would expect the duration of action of that comparator opioid to be, they limited the pain scores that they included to be what was measured when you were expecting to see a benefit from the full agonist, which is good. So they didn't just look at, hey, once that short-acting opioid is worn off, how does it compare? They tried to compare apples to apples for when both of those drugs are actually effective. Now, because pain reporting was all over the place, they tried to standardize it. So they tried to convert it to actual scores on the numeric rating scale. But many of the studies reported reductions in pain intensity. So instead of saying, hey, I rated my pain as a 9 out of 10, and now it is a 5 out of 10, they said, hey, this reduced my pain by 30% or 20% or 10%. So what they did to the best of their ability was then looked at the baseline pain scores reported in those studies and then tried to say, hey, if this was a baseline pain score and they reported it reduced their pain intensity by 10% and their baseline score was a 10, that would mean it went from a 10 to a 9. So they could try to standardize those pain scores between the different studies. They evaluated for bias with the Cochrane risk of bias 2 tool. And then they also evaluated, they did that for all outcomes, and they also graded all outcomes based upon their strength of evidence using the grade approach. And once again, they did this with 2 specific reviewers, and then any discrepancies in the rating of bias or strength of evidence was adjudicated by a 3rd reviewer. Ultimately, their outcomes, they looked at the standardized mean difference. So what was the average pain score across all the reported time points? And then what was the standardized mean difference? So what was the difference in their pain intensity prior to the study compared to after receiving the drugs in the perioperative period? They also tried to rescale it to improve interpretability. So rather than just reporting a standardized mean difference, they then rescaled all of those, like I mentioned earlier, into an NRS scale. So you could see, in general, how much buprenorphine is going to reduce a pain score on an NRS scale compared to another opioid. And they also looked at how many requirements for rescue analgesia or side effects that were there. They used a random effects model with maximum likelihood, which is an effective process when there's high heterogeneity in a meta-analysis. Being there's 58 studies using a ton of different formulations of bup, a ton of different formulations of other opioids, and a ton of different surgical procedures. They expected some high heterogeneity there. And then they adjusted these values with the Knapp-Harding adjustment, which is helpful when there's small sample sizes. Again, many of the sample sizes were between 20 and 30. They did subgroup analysis on specific opioid comparators as well as PCAs. They removed outliers that were outside of the 95% confidence interval. They looked at how effect sizes changed over time. So at a certain point, was there a difference in the impact of buprenorphine in these studies? They try to use intention to treat studies whenever possible. They considered any study that included the dropouts and protocol violations in their ultimate results. They concluded that those were intention to treat studies, even though they didn't specifically say it in the study itself. And they defined statistical significance as less than 0.05. So getting into the results, 58 studies published over 46 years. 8 of them had multiple arms, so that allowed for 69 total comparisons between buprenorphine and other opioids. The average pain intensity was 3.86 with the bup group and 4.66 in the comparator group. So generally, these were patients with mild or moderate baseline pain post-operatively. So not typically patients with severe post-operative pain. So what did they actually find? So their primary outcome was that standardized mean difference. They found a standardized mean difference of negative 0.36, and that was statistically significant. As you can see, that confidence interval does not cross 0. So that's showing us that we had a slightly larger reduction in pain intensity with buprenorphine compared to the comparator opioids. Looking at heterogeneity here, they found that there was statistically significant heterogeneity across the trials, which makes sense based upon the description of the trials. They also ran an I-squared analysis, so looking at this to say that most of the variability in these study results is actually due to the fact that there's a lot of heterogeneity here. So essentially we're seeing, hey, there's a slight reduction with buprenorphine and pain intensity compared to comparators. There's a ton of heterogeneity here, and the likely wide variety of results that we're going to see from study to study is likely due to the fact that there's differences in the studies themselves, not just sampling error. They found that was a pooled effect was still significantly below 0. So what they're essentially saying there is, despite that variability between the different contexts, it still was statistically robust. They then compared that to the 95% prediction interval, which is a lot wider and it crosses 1. So really what that suggests is, again, because it's really context dependent and there's a lot of heterogeneity, it's a recognition that these are the results we found, but the results that you are going to see in a future study are going to be highly dependent on the context. So what type of surgery, what type of opioids, what level of pain, etc. So future studies may find benefit, no effect, or small harm. When they rescaled it to the numeric rating scale, so how did it impact the score out of 10? They found a reduction of negative 0.73 out of 10 with buprenorphine compared to comparator opioids. Again, similar findings in terms of a lot of heterogeneity, variable results based upon context. And again, not exactly sure what you're going to find when you look at it. Again, it's going to be context dependent. Because there were inclusion of partial agonists and their goal was to compare it to full agonist therapy, when they removed partial agonists, so studies looking at nalbuphine or pentosazine, they still found a significant reduction in pain intensity, so that was not driven by the fact that there were studies comparing it with partial agonists. When they just looked at full agonists, those effects still held up. For duration of analgesia, buprenorphine lasted longer. It was about 8.5 hours compared to for common things like IR morphine, where you're going to see about 3 to 4 hours. So we see a longer duration of action with buprenorphine. In part, in relation to that, you saw a large reduction in how many patients required rescue analgesics. So they got this dose, but then they also had doses of IV opioids available typically for rescue analgesia if the dose of buprenorphine or the comparator opioid wasn't effective enough. And they found an odds ratio of 0.4. So you were significantly less likely to require rescue analgesia if you were in the buprenorphine group. When they looked at adverse events, they really saw no statistically significant differences with any of these adverse events. What's important here is, again, they just looked at short-term reactions. They didn't look at long-term evaluations like pain outcomes, development of dependence, opioid use disorder development, persistent pain, etc. These just looked at short-term perioperative adverse effects. Most of the studies showed a low risk of bias. They also looked at publication bias. It was not suspected for any of the outcomes except for in pruritus, but those results were not statistically significant anyway. Almost all of the profiles for evidence showed moderate certainty, ironically, except for pruritus. Pruritus, they showed high certainty of the evidence, but they also found strong evidence of publication bias. So that's a weird discrepancy to kind of rationalize there. So kind of takeaways here. The patients on buprenorphine, they showed a reduced pain intensity. They saw a lower need for rescue analgesia. They saw an average duration of analgesia of 8.5 hours and no significant differences in adverse events. Now, it's really interesting when we consider the average duration of analgesia because generally we do not recommend the use of controlled release opioids post-operatively, in part because that longer duration of action can contribute to dependence, tolerance, and eventual persistent opioid use. So while buprenorphine is theoretically a pharmacologically safer option, it is interesting to think about how it has a longer duration of action, and if that duration of action being similar to an ER opioid is actually going to be more effective because of its pharmacology, or could actually bring some consequences because of its longer duration of action. The other thing from this standpoint is clinical significance. So it was found to be statistically significant, but typically clinically significant reductions in pain are cited as being about a 10% reduction. That mean difference of minus 0.73 is below that threshold. So while it was statistically significantly lower in the buprenorphine group, it was questionable if it was really clinically significant. Other meta-analyses that were done in the past also found no statistical difference in pain reduction between buprenorphine and morphine. But again, those only really compared it with morphine and then included pediatric patients and non-surgical pain, which is less relevant for our post-operative discussion.
Hi, Dan. Just a clarification there on the last slide. Is it for the clinical significance that minus 0.73 is relative to the opioid, right? Like there's probably a 10% reduction in pain from baseline, but then relative to the other opioid, it was minus 0.73.
Yes, exactly. So that is not just what it reduced in pain, it's how it reduced your pain comparatively to the other opioids. So it's still effectively reduced pain. It's the question of, was this clinically significantly better than the other opioid?
Right.
And the answer to that question is kind of questionable.
Mm-hmm.
Great question. Thank you for asking that. I'm glad I was able to clarify that. All right. So ultimately what we see here, yes, there's partial agonism with buprenorphine, but we shouldn't assume that that means it's partially efficacious for pain. It shows similar efficacy and similar safety when compared to other opioids in the post-op period, but specifically that is for adult patients that don't have a history of chronic pain or opioid use. Now, where this fits into practice kind of depends on what the results show because of the unique pharmacology. So it has a higher opioid receptor affinity than most other opioids. Pretty much any other opioid it's going to have a higher affinity to, unless it's sufentanil. Sufentanil does have a higher affinity than buprenorphine. So that's important because it looked at non-chronic pain in patients not on opioids. So how you actually implement this in patients who are already on opioids or have dependence on opioids is going to be potentially a bit different because that affinity means it's going to kick those opioids off the receptor and you have a chance of precipitating withdrawal. So important that we're looking specifically at what patient population this was studied in. Now, I mentioned already that generally we like to avoid controlled release opioids in the post-operative setting for pain. Buprenorphine is a longer acting opioid compared to the other short actings. So the question of, is that worth it, or does the long-acting nature of it cancel out the beneficial pharmacology? And that's a question we don't fully know because they didn't really look at long-term side effects. That being said, the big concern with ER opioids is how they're going to impact internalization of receptors and lead to tolerance and dependence. Buprenorphine has been shown to have biased agonism, so it actually has less of an impact on beta-arrestin and more of an impact on G protein coupled receptors, which means it's going to have those same impacts on efficacy, but the beta-arrestin recruitment is really what's largely responsible for the internalization and desensitization of the opioid receptor. So it may actually have less of a likelihood of leading to dependence and tolerance over time, despite the fact that it is a long-acting opioid. Really, there's not a perfect answer to that question yet, but it's all things to consider in future studies. Additionally, it is a partial agonist, but it also has mixed agonism-antagonism. In addition to partial mu receptor agonism, it is a kappa and delta opioid receptor antagonist, and it's a little unclear of how that actually impacts its pharmacology and ultimate effects on patients. Ultimately, it is generally considered to be a lower risk option and have a lower risk for substance misuse and diversion. And potentially safer from a respiratory depression standpoint. There was no difference found in this study in respiratory depression. There was no difference found in other studies, but again, it was a short period of time. Other studies that looked at escalating doses saw that if you kept increasing fentanyl, you would ultimately cause apnea. But if you kept increasing doses of buprenorphine, that would actually eventually peak at a reduction of 50% of their respiratory capacity. So it didn't actually fully result in apnea. You kept going up on the buprenorphine, and eventually it kind of reaches a ceiling effect on its impact on respiratory depression. It also might protect you against respiratory depression from other full agonists that are given as rescue analgesics. So another thing to keep in mind there. And then we'll just finish up here. Strengths of this study. Closely followed the guidelines for systematic reviews and meta-analyses. They used independent reviewers and third-party arbitrators to adjudicate any discrepancies they found. They found statistically robust findings despite the presence of heterogeneity, which was really good. They did a really robust statistical analysis to see how the differences in the studies contributed to the findings and how we should interpret the findings in that context, which is really helpful for figuring out where buprenorphine falls in practice. Limitations, it did include studies with opioids that we don't typically use in clinical practice anymore, such as pethidine and whatnot. They also did not evaluate or do any evaluation of whether these studies allowed for multimodal options or if they were used in one group versus the other. So when were patients getting ibuprofen, Tylenol, gabapentin, et cetera? How might that impact things? They didn't look at long-term outcomes. So the goal here, the theory behind using buprenorphine is that it should be safer, typically from a long-term perspective, but we don't really have that data quite yet and didn't have that for this study. Again, they're relying on subjective pain intensity scores, and then they're standardizing that across various scales. So that's always going to impact the reliability of the findings. They didn't definitively account for prior opioid use, but they excluded patients with chronic pain or substance use disorder. So they felt that they likely did not include patients with prior opioid use, but that was not something specifically included in the studies. And also the baseline levels of pain were mild to moderate. So how this applies to patients with really severe postoperative pain is less clear. So kind of future directions here. Future directions, we want to focus on outcomes beyond pain score. So this is really positive data. This is encouraging for the consideration of buprenorphine as an option in postoperative pain. Knowing it's safe and effective, at least in the short term, but how does that impact things long term? Does it improve functional recovery? Does it reduce the risk of persistent postoperative pain or opioid use or the development of OUD? Theoretically, I think it would make sense that all of those things could happen. But again, that's theoretically, this could happen. So wanting to find data to actually support that or confirm it. And then additionally, how does this used or how can this be implemented for patients with chronic pain, chronic opioid use, or untreated OUD? Does it potentially act as an opportunity to get those patients onto buprenorphine? And how can we do this safely without precipitating withdrawal in our chronic opioid patients? So overall, the conclusion is that there's moderate certainty evidence to show that buprenorphine is more efficacious, although the clinical significance of that is questionable, than full agonist opioids at managing acute postoperative pain. And what my key takeaway is kind of cutting through all of that in general. I think it's reasonable to consider buprenorphine as a first-line option for patients with postoperative pain management if they do not have a history of chronic pain or opioid use. and they're undergoing a procedure expected to cause mild to moderate postoperative pain. I think there's certainly a pathway forward for use as a first-line option beyond those criteria, but I think what the data currently really supports is if you don't have a history of chronic pain or opioid use, you have mild to moderate postoperative pain, buprenorphine seems to be similarly efficacious to other opioids and is a completely reasonable first-line option. I don't quite feel comfortable saying it is more efficacious despite what was found here because of the heterogeneity, but at times, in certain contexts, it may be more efficacious than other opioids. But theoretically, the hope is that it would be a safer option. I included references here and am happy to answer any questions that you guys have. I know I went a little bit beyond the 30 minutes, so sorry about that. The meta-analysis takes a lot to get into all the details there with 58 studies. So I apologize for going a little bit long, but happy to answer any questions and discuss.
The thing well, first off, really great presentation, really great paper as well. I keep going back to the heterogeneity that you were talking about, particularly in like the mild to moderate pain that was studied here, but certainly there was heterogeneity in the amount of pain, like baseline pain. And it seems like such a rich data set with like 1,300 people per group. So is there any like future goal that the authors discuss on splitting this and doing like sub-analyses on different groups of people?
So they did do some subgroup analyses. I think there's the potential for more. The way they split it out is they did comparators between, they did subgroups of the different surgical procedures and saw which ones were potentially driving that. And then they also did that for specific comparator opioids. So patients on morphine versus fentanyl versus tramadol, et cetera, as well as patients on PCAs. What they did not do is a subgroup analysis on like only looking at studies where patients had severe pain or something like that.
Right.
I think that could
Yeah.
be really advantageous. I think, but they didn't actually talk about that. But I think that's something that could certainly be done in a future study and would probably be effective. The other thing I realized I forgot, I do have for those subgroup analyses, I included just the pictures from the supplemental appendix, just of the ones that were found to be significant. So for comparator opioids, the significance was largely driven by studies comparing it to morphine. That was the majority of the studies. And then if they looked at specific surgical contexts, those surgeries that found it significantly different were cardiothoracic surgeries and orthopedic surgeries. Cardiothoracic only has about 3 studies here. Orthopedic does have a few more. So that's what was driving it. The others did not quite show significance, but none of them showed significantly worse outcomes.
Yeah, I think that's super interesting. Thanks.
Dan, thank you so much. That was awesome. I learned a lot. Really great.
Thank you.
I have a question for you about the chronic pain, chronic opioid sort of subcategory. Like I
Yeah.
agree with your takeaway from this meta-analysis, but what does the evidence support in that category? You know, beyond multimodal. If you're going to grab an opioid, what would you grab? And do you think there's a case to be made potentially for buprenorphine in that category, like as kind of a opioid sparing opioid? It's kind of multimodal by itself. Is there a role for it in that category? Let's say just the chronic pain separating from the chronic opioid just because of that theoretical concern of precipitation of withdrawal. Like what do we have that's out there, you know?
Yeah, absolutely. Great. It's a great question. And I think the big thing at the end of the day is it's largely going to have to be individualized for that patient population because there's so many different contextual factors that are going to go into that decision. I certainly think it's reasonable to consider buprenorphine based upon this in patients with chronic pain, especially if they're not already on opioids. I think I would look at this and say, well, if this is good for patients who are just having acute pain and you're not on opioids for your chronic pain, I would feel pretty comfortable still using this as an option. If they're on chronic opioids, then I have some other questions about how much are they taking, if they're dependent, like if I think giving them buprenorphine is actually going to precipitate withdrawal. So that depends a lot on what they're taking, how long they're taking it, if they're consistently on it, if they have OUD. The other thing that can be considered here is a lot of the doses are fairly small. So most precipitated withdrawal is really seen when we're using OUD doses for buprenorphine. So we're talking 4 milligrams or so multiple times a day. This is a lot less. Typically, the sublingual dose was about 1 milligram. And we actually do, at my institution, I do a lot of microdosing inductions. And that's actually the start of our microdosing protocol because we can give that dose without precipitating withdrawal, even in someone who is dependent. So some of these doses could actually still be used in a dependent patient on opioids. The question then really becomes, how frequently can you redose them? I can give them that first dose, but how many doses can I give before it actually starts to precipitate withdrawal? So that becomes a little bit of the question, but you're always able to kind of start and see from there. So I think in those patients that you're not overly concerned about precipitated withdrawal, I think this is perfectly reasonable as an option. If you are really concerned about that, then I think sticking with some full agonist options is still a good opportunity. The other thing I've sometimes done, and this is getting a little bit beyond this journal club, but just talking about implications of this in practice, is if someone would benefit from buprenorphine long term, but we're not necessarily sure about if it would work effectively for them postoperatively, you can use full agonist opioids. And while using that, you could do a microdosing induction and actually slowly replace that with buprenorphine so that by discharge, maybe they're getting full agonist opioids in the immediate post-op period, but then by day 5 or 6, when they've gotten to their full dose of buprenorphine, you can cut that full agonist opioid and continue on buprenorphine. So if there's a patient with OUD who might benefit, there's another strategy there. So kind of varies, it has to be individual, but that's the kind of things I would be thinking about there. Hope that answers your question, and happy if there's other questions that come up from that.
No, I got one more, but I don't want to hog the mic.
No, I just have I think it's more of a comment than question. So first of all, Dan, it's a great presentation. I think you already mentioned about having this, the antagonistic effect of this buprenorphine for the kappa opioid receptor. And as we know, the core antagonists have a lot of, their literature out there, both preclinical and clinical, that these core antagonists can have the antidepressant and, anti-anxiety effects. So I think, I mean, I don't know, maybe I have missed it. So in that systemic review, did they ever mention anything about testing the affective component of the pain? Because I think whenever we come to the acute or chronic post-surgical pain, most of us, we focus on the sensory component, but there's a big affective component. And as you have already mentioned, the effect of this buprenorphine towards the kappa opioid receptor, which is antagonistic, so that might have an, anti-epileptic or, anti-anxiety effect. So that might kind of affect the overall, outcome. So sensory versus the affective component. So I would like to know your take on that.
Yeah, absolutely. And that's a great question as well. And I will say this study really did not consider that or look into it very much. They kind of left it as, hey, it also is a kappa antagonist. So how does that how does that impact things? We don't really know. I think there is, like you said, more data about what we can kind of infer from that in terms of buprenorphine's effect on the other components of pain and whatnot. There's studies that are showing that while buprenorphine is not something we necessarily consider in central sensitization, it actually seems to have some supposed benefit in patients who show central sensitization and that kind of aspect of nosoplastic pain. So there is some supportive data there, which I think gives us some additional credence for considering this. But it wasn't a specific focus of their review. Hoping that answers your question.
Yeah. All right. Thank you.
All right, Dan, here's my second one.
Okay.
I love this. So there's a lot of enthusiasm out there in the acute pain world for, say, methadone. Single doses of methadone. There's a guy from Duke. You should think about some of his papers. His name's Evan Karish. He's published a lot on this. And what they find is this opioid-sparing opioid thing that happens. You get about 24 hours of analgesia from this long-acting opioid for all its flaws, which is a whole other talk. Buprenorphine seems to fit the same mold. So I mean, and I know we've been warned against long-acting opioids for good reason, like OxyContin. And you kind of just addressed this in the talk. Is buprenorphine like a different animal? Basically, we don't know. But what do you think? I mean, if you're a
Great
patient and
question.
you're if you're undergoing your knee replacement or thoracotomy or laparotomy, you're probably going to need around-the-clock opioids basically for a few days at least. Many of our patients go home with a week, 2 weeks, probably overkill. But in that scenario, where do you think these have a role to play?
Yeah, it's a great question. And I don't know if all the evidence is fully there for me to flesh out and say this is specifically what the role should be. Looking at it, I will say I think that concept of the long-acting methadone makes a little bit more clinical sense, at least to me initially, compared to this impact on central sensitization, because methadone also is an NMDA antagonist, and that's really one of the primary drivers of that development of persistent post-surgical pain. So I think mechanistically, that seems to make more sense in preventing the development of that than buprenorphine. But like I mentioned, there does seem to be some studies that have shown real-world benefit of buprenorphine in central sensitization. So there's more to the story than just NMDA antagonism and whatnot, but I don't know if we fully elucidated all of that yet. I think where I fall with the long actings is I think this is a reasonable approach for buprenorphine, especially because of the partial agonism. I think that one-time doses of methadone is an interesting and promising area. I would focus really on context-dependent introduction. So I would certainly consider doing that, but I would really limit it to procedures and patient populations where we already have some data. I will say, just personally, I'm also aware of some surgeons who are really excited about that option of a higher dose of methadone perioperatively. And I've seen a few patient safety events that we've put in about patients just getting a hefty dose of methadone. So I think with the risks of methadone, and again, when we talk about opioid overdoses, yes, it's driven by illicitly manufactured fentanyl, but in that prescription opioid category, if there's an overdose on a prescription opioid, it's usually methadone. So I take that into consideration there, and I think there's a lot more risk to it. So implementing it, I would be a little bit more cautious in when I'd be willing to do it, versus this, I feel a little bit more free to, if you will, about when it might be appropriate, and what the risks of it would be. The other thing I think is interesting that's kind of related to that is we've been doing a lot here looking at preemptive analgesia, and actually starting NSAIDs and Tylenol and gabapentin and whatnot, not just right before surgery, but actually for about 2 days prior to surgery to get them closer to steady state. It's just a small group of patients, but I'm interested to see how that compares, because that I think is a lot lower risk than perioperative methadone. That being said, I wouldn't be shocked if it has a lot less benefit in terms of the development of persistent postoperative pain than methadone, but it may have a lot less risk. So it all kind of depends on what that ultimately shows out. I don't think there's enough data to answer it perfectly, but that's kind of where I think it's going and where I see future directions in this. Great questions. Thank you all for questions, and happy to take any more. Or just discussion that people have, or if there's comments people want to make.
I think that might be all the questions.
All right. Well, thank you all so much for your time, for giving this journal article a read, for listening to me blabber on for the last hour or so, and for asking great questions. I really appreciate it. And if anyone has future questions or whatnot, I can put my I actually don't know if I have. I'll put my email in the chat as well. So if anyone has any future questions about this or just anything else that comes up in the future, feel free to reach out. Let me know. Always happy to discuss, collaborate, whatever it might be.
Dan,
Thank
this
you,
was a
Dan.
phenomenal presentation. Thank you very much for volunteering to do this.
Thank you so much. Thanks for having me. All right. Bye, everybody.
Thanks for attending, everyone.